Okay. Okay. Hi everyone. So I'm sorry, I didn't realize you had another one just before. So this is probably a little bit of a lot. Um, Sorry, I can't click anything without doing something. Um, but yeah, so do like go grab a coffee or whatever. As we'll start in a second. But yeah, I'm going to be talking about dementia and delirium. So this topic is both in your neuroscience and your psychology. So I've put but yeah, it crosses over in both. Although I think it's quite a common psychology essay, whereas in neuro you might be more likely to see it just in the multiple choice questions. Um, yeah, okay, let's get going because I also think I'm aware that you probably just want to get on with your evening. So, just what we're going to cover. These are the syllabus points that relate to dementia and delirium. So, from your neuroscience, it's 25.3.1 and 2 because they're stupid about the syllabus. So, there's two things with the same number. But you already know that. So, yeah, basically going to talk about global impairment of cognitive function, what that means, types of dementia, including Alzheimer's, and then treatment of dementia. And then again, this comes up in psychology under, again, the same thing, global impairment of cognitive function. Okay, so the plan for this lecture, we're gonna go. I'm gonna keep it short. Firstly, I know you've all probably just had a load of information thrown at you, and you need to go like eat, sleep, revise if you want. Do make sure you eat and sleep though. So yeah, firstly, we'll just go through some syllabus content, which is mostly stuff from your lectures, maybe a few extra sort of references and things that you might be helpful. But hopefully it just sort of puts things into context for you a bit more. I think at this stage, probably though, if you're going to write an essay on it, the essay plan will be helpful. If you're not, then don't worry too much about the detail. Just sort of survive MCQs. Wherever it is a syllabus thing, the syllabus reference is in the bottom left of the slides. So you know where we are. But yeah, so I know exams are soon, so I feel like an essay plan is probably maybe the most useful thing to you now. So we're going to go through at the end an essay plan of dementia. So a lot of the psychology essays I'm sure you've seen are fairly repetitive. So there's at least sort of 4 or 5 in the past. There's been at least 4 or 5 questions on dementia, and it's basically the same question on types of dementia and cognitive assessment to sort of diagnose dementia. So we're going to run through an essay plan for that because I feel like although in the lectures you hear quite a lot about types of dementia, the sort of cognitive assessment bit is not really discussed. So it means you can't really access that essay. So hopefully I can give you some examples and some references and give you another essay plan in the bag if you want. So let's get going. Also, sorry, if anyone has any questions as I'm going through, I hopefully can answer them. I can't promise, but do just shout because if you put something in the chat, I might not see it. So do just yell. Yeah. Okay. So firstly, let's look at some syllabus content. So overall, within this topic, it talks about sort of 3 main changes to cognitive function that can happen. So that's normal aging, which does have some sort of established changes. Then you've got delirium and dementia, and these all sort of slightly, so normal aging is sort of like mild changes. Dementia is very, well, increasingly severe changes, and delirium is something a bit different. But it's important to remember that delirium and dementia are sort of umbrella terms. There's lots of subtypes within them, which we're going to talk about. But it's good just to have an idea of the overall picture. So then also we'll talk about types of dementia and how we can classify them. And you might think, oh, why is it important to classify them? Well, at the moment, to be fair, it's helpful in that you can give someone a more accurate diagnosis and support them, but our treatments are pretty rubbish. But in the future, hopefully our dementia treatments will get better. They'll get more specific for different types of dementia and therefore become more important. So firstly, let's just talk about normal aging. So when people age, your semantic world knowledge, just like how much stuff you know, increases, but your ability to process that decreases. So your processing speed and your memory in general decrease. There's also some brain changes associated with that. So you get basal ganglia and hippocampal atrophy. You get more mitochondrial mutations, which mean that you can't really deal with oxidative stress very well. You get more reactive oxygen species, which again just further degenerates the neurons because they can't cope. And also there's changes to your blood-brain barrier permeability. So you end up being less able to deliver nutrients to your brain and less able to remove toxins. But it's not all bad. So the brain does adapt. So it recruits additional neurons to make up the deficit that's there. And you can also get de-differentiation of different parts of your brain. Again, to like, if you haven't got enough going on in this part of your brain, you de-differentiate and recruit other parts of your brain. So I think this is kind of a useful diagram on the right that you've probably seen in various forms before. So you've got this idea that as you, sorry, it's time on the X. I've managed to chop that off. So as you progress through aging, your cognitive function is going to go down. I don't know if you can see my mouse. Anyway, cognitive function goes down a bit. That's normal. If you go down a bit more, that's called mild cognitive impairment, which is a fairly fluffy term for like you're a bit impaired, but you're kind of all right. And then you get what people call dropping off a cliff when you go into dementia. So you get this kind of rapid decline, and at that point you haven't got mild impairment, you've got dementia. And from there, there's different severities of dementia. So firstly, I think, so that's normal aging. We'll now just briefly talk about delirium, and then we'll get into dementia because that's the main part of it. So delirium. Delirium is, it's a bit confusing to know what it is, but it's kind of that confusion, reduced awareness, disorientation, which people often associate with aging, but it's not constant. Like if you have sort of these symptoms when in aging or in dementia, they're pretty constant. They're just going to get worse. Whereas in delirium, it can fluctuate. It can be worse one day, better the next. It can be also associated with delusions and hallucinations, which aren't really the case in most forms of dementia. And the risk factors for delirium include age and dementia, which is like they're all kind of related, but also infection and dehydration. So if you've got an older patient and they're suddenly just hallucinating and going completely wacky, often it's just they have a UTI or something, and they're delirious. And you treat it and they're back to normal, which is quite cool. Okay. So on to dementia, because there's kind of a lot to go through. So yeah. Dementia, so the prevalence dementia is increasing mostly because there's an increasingly aging population. But also it means that the burden to the UK health budget is increasing as well, which makes these understanding dementia and getting new treatments really important. So dementia presents with a decline in memory, cognition and reasoning, impaired communication, and crucially, it's these kind of declines, but beyond what's expected for your age. Otherwise, that would just be called normal aging. Yeah. So there's 5 main types of dementia. I'm sure you've sort of heard a lot about these by now. So the big one that we always talk about is Alzheimer's disease, and that's because it's responsible for about 50% of, well, at least 50% of dementias in later life. And also is responsible for about 20% of the UK's health budget. So it's a big deal. So Alzheimer's disease is characterized by amyloid plaques and tau tangles, which both work together to kind of damage the synapses and the neurons, so you get neuronal cell death. So that's at a cellular level. Then at a more sort of systemic brain level, you get thinning of the medial temporal lobe first, and then that thinning and atrophy of the brain spreads out from there. So that'll become relevant later when we're talking about how to diagnose different types of dementia. Then we've got frontotemporal dementias. So you can remember these, they're kind of similar to Alzheimer's because you've still got amyloid or tau, but it's sort of in atypical locations. That's why it's not just Alzheimer's. And the location of the amyloid or the tau dictates what variant and what kind of effects you're going to see. So if it's frontal, so the frontal variant, you get more behavioral changes happening. Whereas if it's a temporal variant, so there's changes in the temporal regions, you get these aphasias and a semantic dementia. Then quite different, you've got a vascular dementia. That's when there's some vascular event that's caused the dementia. So usually with that, you get much more sudden changes to how the person's presenting and a really fast progression of the disease, because it's much less gradual, it's more drastic. Then different again, you have Lewy body disease, which kind of obviously is characterized by the presence of Lewy bodies in the brain. And that's a bit different. You seem to get motor symptoms, sleep changes, visual hallucinations. So a little bit like we're talking about with delirium. I said, oh, delirium is different because you get hallucinations, which you don't really get in dementia. Lewy body disease is kind of the one where you can get hallucinations going on. And then finally, there's I don't know how to say Creutzfeldt-Jakob disease. Sorry, that's meant to be a C, not a K in Jakob. My bad. So that's a prion disease. So it's a little bit different, and you get these aggregates of misfolded protein that can spread and then result in neuronal loss, like the other dementias. But quite distinctly, it makes this spongiform encephalopathy. So it basically kills off really big chunks of your brain. So if you scan these people's brain, and it's severe enough, you can see that spongiform encephalopathy. Oh dear, I don't think I said that. So that defines that type of dementia quite well. Okay. So now thinking about risk factors and protective factors for dementia, they're all reasonably obvious. So the fairly usual risk factors: age, genetics, which we'll come on to later. So especially late onset dementia has some genetic factors implicated in it. If you have central nervous system trauma, that can obviously damage your neurons and can be related to dementia. Your classic lifestyle risks, so obesity, hypertension, smoking, diabetes. Depression is linked to it, also poor sleep, hence try and get some sleep for the next few weeks if you can. And then protective factors. So I feel like we always talk about risk factors for dementia or anything, whereas protective factors are also quite helpful when we're talking about preventative medicine. So things like a Mediterranean diet, education. There's this idea that if you're more educated or more cognitively capable, you decline X amount when you age. So if you start with more cognitive ability, which is associated with education, that decline takes longer to get to a stage where it's really a problem for you. Although, as with all of these kind of studies, there's obviously that, well, there tends to be a correlation between how educated you are and maybe what your cognitive abilities were before you were educated. So it's not always certain whether these kind of factors are correlative or causative. And also exercise is protective largely because of the cardiovascular benefit to it. So that especially helps with things like vascular dementia. Okay, so on to diagnosis. So there's a fairly specific like set of things that you want to say or be able to say if you're talking about, or how do you diagnose dementia? So the bits that are important are highlighted in bold, which is unfortunately most of it. But so to diagnose dementia, you need multiple cognitive deficits, including in memory. So that's what's common to all of the dementias. And it has to lead to a functional impairment, which basically means it like has a functional outcome, like it bothers, it impairs your function. Sorry, that's rubbish. Anyway, so for more than 6 months. So if it's just a brief spell, it might be something like, oh, you're a bit delirious, maybe something's happened. But for more than 6 months, it's probably dementia. Also in clear consciousness, so not affected by other things, and representing a change from a previous level of cognition. So it has to be a decline rather than just you're always like this for some other reason. There are some obviously issues which we've kind of talked about and are probably obvious to you, that if you have a very high cognitive function normally, it takes more decline before it's a problem for you or like other people really notice it, which often means that it can delay you getting help. So if you go to the GP and say, oh, I think I've got early signs of dementia, and they go, no, your cognition's great, that's not important. It's like, is it worse than before? So these are all just things you can discuss in essays, especially psychology essays, where you're allowed to be, I don't know, it seems to me that you're allowed to be a little bit more discussive and talk about things like this. So now we're going to go on to talk a bit more about Alzheimer's disease, because there's sort of that whole section in your syllabus specifically on Alzheimer's. And out of all of the dementias, that's the one that's sort of discussed the most. So we'll chat a bit about this. So yeah, also as I mentioned before, sorry, it's the most common one, and is becoming increasingly problematic. So the first question that you want to ask yourself is Alzheimer's just normal aging? So there was this idea before that of the threshold hypothesis. There was this idea that all aspects of Alzheimer's disease are seen in normal aging too. The references are in brackets. The references is always like Roth et al. I just got rid of the et al. Because that's obvious, and no one needs to remember more than one name for a reference. I think it's silly. So there's that idea. And then some other dude afterwards was like, yeah, that makes sense. And he proposed the idea that, okay, if we just all live long enough, we will all get Alzheimer's because it just happens at different rates. If you live long enough, you'll get it. But then this was later disproved. So Smith in 2002 did a study saying that, so basically got a bunch of people who were 85, and he found that by 80 or around 85, and found that by 85, nearly everyone has this pathology like you see in Alzheimer's disease, but not all of them actually had the symptoms of Alzheimer's, meaning that there's a sort of funny disconnect between the pathology that we see in Alzheimer's and the symptoms themselves, which is interesting and will come up later. So then, okay, so we think Alzheimer's, yeah, it's definitely a thing. It's not just everyone getting old. So then what's the histopathology of Alzheimer's? So the two main things are you've got extracellular amyloid plaques, which is this insoluble A beta peptide, and you've got intracellular tau tangles. So this is tau, but then it becomes hyperphosphorylated and ubiquitinated and makes a mess of the inside of the cell. So both of these together basically mean that the inside of the cell and the outside of the cell can't function normally. You get neuronal cell death, and the neurons can't communicate particularly well with each other. So then you can say, okay, we've got these two things going on. Which one is the problem? So the answer is we're not too sure, and it may be both of them. So you could say, okay, it seems to be like it's tau, because if you have pure tauopathy, meaning that you only have tau tangles, you don't have any amyloid plaques, you can still get this sort of pathology, you still get symptoms. So then you think, oh, the amyloid's not a problem. Also, if you immunize, we'll talk a bit more about this later, but there was an idea that you could immunize people against the amyloid plaques. So basically you just vaccinate them and then their body degrades them. And that worked. Like, you could remove the amyloid plaques, but you didn't reverse the decline in cognition, which then you think, oh, okay, maybe it's because the plaques aren't important. Tau is the problem, didn't target the problem. Alternatively, it could be that the plaques are the problem, but maybe they're only problematic when they're being formed or something, or yeah, the damage is already done. So just getting rid of the plaques doesn't fix the problem. It just sort of, I don't know, takes the plaques away. So yeah, we're not really sure about that, but that's something to consider. Then again, risk factors for Alzheimer's. So obviously all the ones that are we've talked about for dementia as a whole, but especially exercise seems to be implicated for, again, for cardiovascular health and also cognitive ability. So just a reference for you guys, you've probably got this already, but just I think it's quite a handy study to know. So the nun study in 1991 to 93 basically took 678 nuns. Nuns is important because they were living all in the same place, all with the same environmental factors, not anything else. So they, at age 22, they all wrote an autobiography. And then at age 80, some of them got Alzheimer's. And they found that there was a correlation between a positive correlation, a negative correlation, sorry. So the more grammatically complex their autobiographies were, the lower the incidence of Alzheimer's was at age 80, which, yeah, just sort of is evidence for this idea that the higher your cognitive ability, the less risk you are of getting Alzheimer's, or maybe you get it later. So types of Alzheimer's, two main types of Alzheimer's, late onset Alzheimer's disease, or LODE, and early onset. So late onset Alzheimer's is just the normal Alzheimer's that you hear about. This is almost all cases of Alzheimer's. It occurs in those above 65 years old. It has a very complex genetic susceptibility. So we think there's definitely some implications of these ApoE alleles, with epsilon 4 allele increasing the risk of Alzheimer's and epsilon 2 decreasing the risk. This is due to their effects on the different amyloid production or degradation. But then with early onset Alzheimer's disease, so there may be other genetic things going on there as well, but those are the main ones that we know of. But with early onset Alzheimer's, it's very rare, like less than 1% of Alzheimer's cases are early onset. Early onset meaning less than 65 years old. But equally, the genetic component is quite simple. So it's a Mendelian single gene inheritance with mutations in either the APP or secretase genes. So then on to treatment. Okay, so there's a variety of treatments, and this is a kind of bit where you can make it a bit more interesting. You can talk about new treatments as well. So the standard few treatments that you'll need to be able to sort of regurgitate for a multiple choice. The classic one is acetylcholine esterase inhibitors. So because acetylcholine esterase is going to degrade acetylcholine, these are going to leave more acetylcholine there. So an example of this is rivastigmine. So basically, because in Alzheimer's you get this neuronal death in the basal forebrain, especially the basal forebrain provides a lot of the cholinergic supply to the brain. So the idea is that because you've got this death, you're then lacking acetylcholine in your brain. So you think, ah, great, we just inhibit the acetylcholine esterase, you get increased acetylcholine kind of everywhere, and that can help the signs of dementia. But it's also important to note with all of these treatments that dementia kind of only goes one way at the moment. Like none of these treatments are curative or disease altering. They're just helping manage the symptoms at the moment, really. So then the other pharmacological intervention is NMDA receptor antagonists, such as memantine. So the idea here is that if you have excess glutamatergic transmission via these NMDA receptors, that can produce excess cytotoxicity. So then you get, and because of that, you get neuronal death. So the idea is if we antagonize these receptors, you can sort of damp down that glutamatergic transmission, and then you reduce the death neuronally. Sorry, these aren't meant to be under pharmacology. This is my mistake. But other treatments that are not pharmacology include cognitive stimulation therapy. So this is like basically just, yes, stimulating cognition, but not through pharmacology. So you can do group activities and exercises to help sort of improve memory, stimulate memory and language, especially in older people where they're not sort of having that stimulation going on. Also reminiscence work. So people can use props and things that are from a patient's past to first improve their mood, but also, again, just challenge memory, things like that. Then other sort of newer treatments we talked about before, this immunization against A beta 42, the problematic amyloid plaque. There's a bit of, as we talked about, it could be helpful because it reduces the plaques, but again, they didn't actually find any changes in the symptoms. So you can sort of discuss that maybe in an essay if it came to it, because that's quite an interesting option. But then because we talked about that saying, oh, maybe the amyloid is not the problem, maybe the tau is the problem, there are these new ideas for new molecular therapies. So one of them is to increase the clearance of the amyloid plaques, neprilysin, or also antibodies against the amyloid plaques, aducanumab, not sure. Again, so those are promising, but not too sure about the effectiveness of getting rid of amyloid plaques. But then equally, maybe tau is a problem. So there's these ideas that we could develop therapies to inhibit tau aggregates, or kind of like the same as with amyloid, produce antibodies against tau. So those might be helpful. And again, might be something for the conclusion of an essay or something. But these treatments do kind of have problems. So firstly, inherently, if we're seeing these cognitive changes in someone, diagnosing them with dementia and then saying, oh, you could have this treatment, is already way too late. Like they've already lost a lot of neurons to the point that we can see it in them. So ideally, we want to start preventing rather than curing, or treating really early on, so that we can prevent that loss in the first place. But obviously this is dependent on our ability to diagnose dementia, so we'll come on to that later. We also need models of dementia in order to be able to find treatments for dementia, and mice really aren't great for this. So again, this is something you can discuss in essays. So mice in general don't get neurodegenerative diseases. They're just better at us than not getting them. Also, sort of relative to their physiology, they don't live as long as us. So like we've been talking about, a lot of these things come on with age, so the mice just don't get them. But still, a lot of our research in these is going on in mice. So possibly the way we induce dementia in mice is maybe not that reflective of how it is in humans, which is a bit of a problem. So, okay. So that's kind of that for the main syllabus bit. I feel like hopefully those have covered some of the main points. Does anyone have any questions before I go on? Nice. Okay. I feel like everyone just wants to crack on. Okay, so on this essay plan. So this is an example psychology essay question. Basically this exact question has come up about 5 times. I mean, there's a few words different, but the point is, it wants you to talk about different types of dementia and the sort of the differences between them, and then talk about how can we do cognitive assessments to work to diagnose dementia and to differentiate between them. So we'll talk about that. So firstly, what would you have in my introduction? So also I'm just saying this is how I would approach this essay. I didn't actually write this essay in the exam, so I can't tell you how well it scores, but this will be my approach. So, but feel free to just take what you like out of it, ignore the rest, etc. So in my introduction, I'd probably just give a little bit of epidemiological data. So the prevalence of dementia is increasing, there's an aging population, the NHS is screwed, etc. Then say, okay, there's lots of different types of dementia. You can state the main 5 that we've talked about, say they're all different, and then talk about this idea that classifying them is important so that we can choose the right support and the right treatment for individual people. But that idea that classification of dementias relies on really good methods of cognitive assessment, and you'll talk about that. So in your first paragraph, I would probably briefly describe the differences between normal aging, mild cognitive impairment, and dementia, and maybe whack that graph in there. Just to say that you know that dementia is not just aging. You could talk about studies showing that. And then we're going to talk about just briefly explain why they're different, or how they're different. Then we'll get into the main bit of the essay. So this question, it always seems to say, describe the clinical and cognitive features of different types of dementia. So just briefly going through each one. With Alzheimer's, the clinical features is like amyloid plaques, tau tangles, medial temporal lobe atrophy spreading to other areas. And cognitive is that memory deficit, primarily. And yeah, frontotemporal dementias, the clinical signs, like we said, is amyloid or tau, but in atypical locations. The cognitive features, they're, like we talked about, depending on whether it's frontal or temporal in location. That means you have behavioral or aphasia semantic dementias. Then vascular dementia, you've got this fast progression, poor localization, especially confusion. Lewy body dementia, your clinical signs are the Lewy body pathology, and then your cognitive signs seems to be associated with motor symptoms, sleep disturbances, and visual hallucinations. And then Creutzfeldt-Jakob disease, this is actually how you spell it, I think. It's better than the other one anyway. So clinical features, you get protein aggregates in these infected cells, you get spongiform encephalopathy, and the cognitive things that you notice is especially speech and memory problems. Cool. Okay, so you can bash that out. That's all good. Now we'll get into the cognitive assessment, which I feel like is the bit that's really lacking in the lectures, or at least it was last year. So what aspects of cognitive assessments can contribute to making a diagnosis? So basically, I'm just going to run through each of the types of dementia, and we're going to talk about the cognitive assessments that you could use for that and how it differs from the other ones. Yeah, I ended up doing a fair bit of reading for this, hence so there should be some references in here that might be useful. So starting with Alzheimer's, as I mentioned before, you get the earliest changes in the median temporal lobe, and that region is associated with episodic memory, which is why basically the episodic memory seems to be the first one to go in Alzheimer's disease. So you can use that. You can test that to see if you think you have Alzheimer's or not. So to test episodic memory, you can use this delayed recall. So you tell people, you're going to tell them something, you wait a bit, you try and recall it after a gap. And that's a good test of episodic memory. So Salmon in 2000 found that you can pretty well 85 to 90% accurately differentiate Alzheimer's patients from other patients using that delayed recall test. However, with all of these, it's probably going to depend on what stage of dementia they're at, but that's sort of caveat with all of these assessments. They also found, it's also been found that Alzheimer's seems to be associated with more intrusion errors. So like you're inserting a random word when you're talking, This might be due to having sort of more cognitive interference or less inhibition. So you're talking about one thing and another word pops in, you can't inhibit it. But equally, oh yeah, that's an interesting word. Okay, so it's hard to differentiate between Alzheimer's, and that's meant to say aging, once you're over the age of about 80. Because again, because your normal aging is getting a bit worse by that point, it can look like Alzheimer's, you kind of get this overlap. So then at this point, I say, okay, so this shows us that it's really important that we need kind of multifaceted diagnostic methods. And then you go on to talk about loads of other diagnostic methods, so it's all good. So then moving on to frontotemporal dementia, like we said, it's sort of umbrella term. Each type of frontotemporal dementia will present uniquely. So it's also been suggested that to differentiate between that and Alzheimer's, you can do this by behavioral science. So that was Curtis, 2006. And some studies suggest that frontotemporal dementia has more impairment of verbal fluency than Alzheimer's, or less memory impairment. But the kind of collection of studies for that use quite small patient samples, and patients at varying disease stages, which means you can't really compare them particularly well. So the evidence there is not great. Then moving on to vascular dementia. So vascular dementia is a fairly heterogeneous presentation. It kind of depends where the vascular event happened. So with this one, you want to assess the patient's cognition and also do imaging. And with this, you want to combine the two. So you can talk about how if you image the patient and you see sort of a focal lesion or a focus of a vascular event, and the cognition of the patient means that it's probably, they're say they're affected by their episodic memory is bad and the lesion is in the median temporal lobe, you might go, okay, that makes sense. Vascular dementia is especially indicated if the patient's had a stroke and then a few months later they get dementia. You're going to be looking out for vascular dementia. So then, while cognitive assessments are useful, you want to talk about the idea that taking into account the patient's history and other things that have happened are also useful. So then Lewy body dementia presents similarly to Alzheimer's, but Lewy body dementia can also give this mild Parkinsonian symptoms and hallucinations like we talked about before. It's just a reference for you. Creutzfeldt-Jakob disease, you can get EEG changes, so that vary throughout the course of the disease. I thought it was quite a cool study. So in the early stages, you get this frontal rhythmic delta activity in the EEG, and then in the later stages, it's a fairly grim disease. Then so you get this areactive coma trace. But also because of the spongiform encephalopathy, MRI is quite accurate to diagnose this type of dementia in about 90% of cases as well. So all of these assessments, you can talk about the fact that there are lots of different assessments used for lots of different types of dementia, and you want to use multiple to make sure that you've got the right diagnosis, because ultimately lots of dementias present quite similarly. So even though the underlying pathology might be quite different, they can present fairly similarly, and aging people can. Okay, so on to how I conclude. So my conclusion to this essay would go something like, classifying dementias is really important, but it's really hard. Different dementias present similarly, but also different humans with the same dementia might present really differently. And also dementias, the presentation of one type of dementia is going to vary according to that person's cognitive abilities, and also what stage of the disease they're at. So to overcome all these issues, we should use multiple diagnostic techniques. And at the moment, although classification might not feel super helpful because there's not that much variation in the treatments, and we don't have super effective treatments for dementia. As we develop more and more treatments, and you can mention a few cool treatments here if you want, this classification will become more important, because then hopefully we'll end up with treatments that are specific to each type of dementia. And then classifying people is important to make sure they get the right thing. So that's all I had. I hope this is somewhat helpful. I wanted to keep it short because I know you guys have got a lot to do. So if anyone does have any questions, please do shoot me a message on the chat or now, or email me. That'd be great. Also, I'd really, really appreciate feedback, even if it's like I hated it. That is very helpful. So yeah, there's the link. It's the same link that was in the chat before. So either scan the QR code or click the link. I'd really appreciate feedback. And then you also can get the slides. Ooh, a message. The way to put this in a biopsychosocial model, or is that more for etiology of other disorders? I think, good question. I like your thinking, especially with the psychology essay. I think it probably can, in that you've got, so hang on, let me go back to okay, ooh, with sort of things like risk, oh, that's rubbish, it's not the slide I wanted. Okay, so in the biopsychosocial model, so you've got some of these risk factors will sort of play into the social factors part of that, and also like biological risk factors as well will come into that model. So I think you could reference that model as being useful to sort of as a way to, or a framework maybe to think about dementia. Yes, but I think I agree. I think, or at least where I've heard that model more is probably with things like depression and things like that. So I think although you could apply it to this, it's perhaps not the sort of the framework way to think about it. But I think it's an interesting thing to think about. Yeah. No worries. I hope that's helpful. A bit. It's been a while since I've done this. What else was I going to say? Oh yeah, just good luck in your exams as well. Yeah, I'm sure it'll be wonderful. They're horrible, but then you'll be done and you can enjoy your FHS project. Okay, I don't think anyone seems to have questions right now, Alicia. So
Yeah, thank you very much, Naomi. That was really good. As Naomi said a few times, please do give feedback. I hope you did enjoy the talk and good luck for exams. And yeah, I think there's one more talk next Monday on viruses if you'd like to join. And yeah, thank you very much for coming.